So the sinus rhythms that we're going to be displaying here are going to be normal sinus or NSR, brady, tachy, and sinus arrhythmia. Electrical stimulus generated from the SA node is considered, this is normal sinus rhythm, being that it is a rate of 60 to 100 beats per minute, right? There's an upright P wave. There's one P wave for each QRS complex. We know our PRI is considered normal. Our QRS is less than 0.12. Now, when you're getting into anything in healthcare, the one thing that I have to say is make sure you understand what normal is. Get really good at looking what normal is. What does a normal person look like when you're doing your assessment? Do they look sick? Do they look not sick? What does a normal EKG look like? When you talk about vital signs, what are normal numbers for vital signs? The second that you get really good at determining what normal is, you're going to be just fine with seeing something that is abnormal, and you'll know exactly what that might be once you start getting into, especially with EKGs. It takes a little bit of practice. But we can look at this. We could say that, hey, man, there's a P wave before the QRS complex. We got an upright T wave, all right? And then obviously there's a little gap here, and then the P wave starts all over again. Looks good. Sinus brady. Remember, it's sinus. So we have an upright P wave. I got my regular QRS complex. Remember, that's considered narrow. And it's delayed, right? For sinus bradycardia. It's less than the intrinsic rate of the SA node. So if the SA node's intrinsic rate is 60 to 100, anything less than that is considered sinus bradycardia. All right. Now, I know somebody's going to say, well, hey, Mike, on ACLS, for the latest updates, they did change that. They said that now it's 50. All right. Anything less than 50. All right. That is American Heart. They did change that in their bradycardia algorithm. But when we talk about what is sinus bradycardia, it's anything less than the intrinsic rate of the SA node, which is 60. Okay. Let's take a look. Now, you might be looking at this rhythm and say, okay, yep, I see P waves, I see QRS upright, and I see my T waves. But the only thing that changed between our last EKG and this EKG is the distance between R to R, okay? Remember, the difference is that distance. Now, if we wanted to do our sequence method, kind of like what we were looking at in the beginning, this is probably the best QRS complex that I would look at, right? This one, the only reason why I say this one compared to the others is this QRS complex sits on a line, right? And I can count how many large boxes in between the two boxes, right? I mean, I'm sorry, between the two R waves. Now, again, I did say this is a 6-second strip. So we know this is 1, 2, 3, 4, 5. The rate is about 50. But we could make it a little bit more accurate. Remember, how we would do that, we'd say 1, 2, 3, 4, 5, probably like 5 3/4. We would just take the number 300, divide that by 5.75, and you would get your answer. Sinus tach. All right, electrical stimulus generated in the SA node. Now, we said that just like our normal sinus rhythm and our sinus bradycardia, remember, we got upright P waves, we got narrow QRS complexes. This is still in the SA node. This is still more of a normal rhythm, right? There's some people that walk around with sinus bradycardia and it's completely normal for them, all right? Now, some people are going to be walking around with sinus tach. Now, the difference between the two is sinus tach, there's always a reason for sinus tach, right? There's not always really a reason for sinus brady. Like I said, there's some people that's just normal for them. If somebody is walking around with sinus tach, obviously it could be because they're not in very good shape and maybe they were walking or they were jogging or whatever the case might be. Some of them might actually be sick and they might have sepsis, and there's so many different reasons for sinus tach. So that's something that we got to think about when we're talking about sinus tachycardia. But it's any rate that's greater than the intrinsic rate. Now, we said that intrinsic rate, again, was 60 to 100. So anything greater than 100 is considered tachycardia, right? And remember, it's sinus because we have an upright P wave and a narrow QRS complex every time. If I got an upright P wave and I have a narrow QRS complex, we're talking about a sinus rhythm. It doesn't change. All right, here we go. We got sinus tachycardia here on the screen. If I counted these R waves, we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. This is pretty damn fast for sinus tachycardia. We're getting close to the SVT range. All right. Not the best EKG for sinus tachycardia to ever show you, and I'm gonna explain why. Now, whenever I look for a sinus tachycardia, I know it's sinus tach and not SVT because I could differentiate T waves from P waves. All right, let me repeat that. I can see that there are T waves and I can see that there are P waves, and I could differentiate the two. I'm not just looking and saying, hey man, this one big blob here, that's probably a P wave, but I'm not quite sure. Here I could still tell there's two notches, and obviously the notch closest to that QRS on the left-hand side is the P, then the other one's gonna be the T, but they're getting too close. And remember that, if you can't differentiate the two and they're sitting on top of each other, you're looking at an SVT. All right, it's going so fast that you can't tell the difference. Everything gets so smushed together. And that typically happens at a rate greater than 150. All right. Sinus arrhythmia, irregular. So all of these rhythms that we've looked at before are considered regular. And if you're not sure what that terminology means, it just means it's on beat. It's the intrinsic rate is firing at the same time every single time. The conduction system doesn't skip a beat. It's in perfect order, right? Now, we look at this sinus tachycardia and we can say, hey man, we're still in that same order. Now let's take a look at sinus arrhythmia. First off, it's irregular, between 60 to 100 beats per minute. So it's kind of like a sinus rhythm. We still have a P wave. Everything looks like a normal sinus rhythm. The QRS, everything is sinus. The only thing that changes is the distance between R to R. All right, you start seeing that there's difference and it becomes irregular. There's an irregular beat with regards to the ventricular contractions that are occurring, these QRS complexes. Now, when you look at, you might look at this and you might say, well, hold up, Mike, wouldn't that be considered AFib? Well, no, remember the atrium for AFib, you're gonna see quivering in between each R wave, right? This is pretty damn stable. And the only reason why I'm saying that this is not a premature contraction is once you print it out, there's going to be a lot of irregularities going throughout this EKG. Now, everything else looks perfectly normal. You're going to have a P wave, T wave, QRS complex, but it's just irregular. All right, that's considered a sinus arrhythmia. All right, talking about some atrial rhythms that we need to look at. First one is wandering atrial pacemaker, or WAP. Not the same WAP that you're thinking about, right? Wandering atrial pacemaker is what we're talking about. We got atrial tach, I got premature atrial complex, a flutter, and AFib. All right, let's talk about the WAP first. So it's irregular, and you're gonna see why it's irregular here in a second. So 60 to 100, just like normal sinus rhythm, but it says that there's a morphology change from one complex to the next with regards to the P wave, just P wave, okay? At least 3 places above the bundle of His. Now, I'm gonna explain that here in a second. PRI is still less than 0.2, QRS is still narrow, all right? Let's take a look at this. Pay attention to the P waves. The P waves change in shape, okay? Over here, this P wave is almost missing, right? Now, some of these P waves, they get crazy looking. They might have a little notch in it. They're all over the place. Now, look at this diagram here of a heart. You're gonna see 3 different stars. All that's trying to signify is where the atrial depolarization is occurring. Now, if you remember what a P wave is atrial depolarization. So with wandering atrial pacemaker, whenever that pacemaker in the atrium is firing, it's firing from different locations. It's wandering. Now, this looks like a regular rhythm. You might look at it and say, hey, man, it looks freaking regular, dude. I see QRSs in the same exact place. Now, what makes this rhythm irregular is that the atrial contractions are coming from different locations. Okay, even though it's still firing at the same time, it's firing from different parts of the heart. Now, whenever you see a rhythm and one of the beats are changing from the conduction cycle, it could be a QRS complex, whatever the case might be, and maybe it's a different shape, maybe it's a different height, maybe it's a different width. Understand, all that means is it's ectopic. It's coming from a different location. We call that ectopic foci, right? It's coming from a different location in the conduction system. And this is exactly an example of showing you what ectopic foci looks like in the atrium, or just with P waves in general. Okay, still looks like normal sinus rhythm. It's just different looking P waves. That's a wandering atrial pacemaker. Let's take a look at atrial tach. Now, this gets a little bit weird. Okay, and the only reason why I'm going to say that is because you might say, well, hold up. Look at that rate, greater than 150. Isn't that considered SVT? My answer to you is yes, it is. Now, the only difference is being able to confirm that there are P waves. Typically, with a rate that's that fast, you have no idea if there's a P wave or an OP wave. All right, remember, if there's no P wave, we're going to be calling that junctional, which we're going to be getting here into a second. So that just means it's coming from the AV node and not the SA node. Because if there is an upright P wave, that means that it is coming from the SA node. So with atrial tachycardia, it's saying that it is regular, greater than 150. We do have P waves, right? Even though it says it can be lost in the T wave, which I've already told you it will be, which makes it very hard to tell what exactly it is. That's why we call it supraventricular tachycardia. But this is known as atrial tach. Now, if you look at this example right here, this heart rate is extremely fast. And I don't know if that's a T wave or a P wave. You just don't. It's too smushed together. Okay. Is it a narrow complex QRS? Yeah, it is. And is it regular? Yeah. Are those P or T, whatever the hell those are those upright? Yeah, they are. Can I definitively say that that's atrial tachycardia though? Not really, man. All right. Just because, again, I don't know if that's a T wave or not. That's why we call it SVT, supraventricular, above the ventricles tachycardia. This could be originating in the SA node. This could be originating in the AV node. I'm not 100% sure. Steve asks, could changing the gain make this easier to read? No, once it starts to get smushed together, you increasing the gain, understand what that's going to do. That's going to increase the amplitude and make it these beats look really tall. Sometimes increasing the gain on an EKG might make it easier to look at some EKGs because some of them have really low amplitude and it's hard to read what you're looking at. So increasing the gain helps, but that's not going to help be able to distinguish atrial tach from, let's say, a junctional tach. You're not going to know. All right, PACs, premature atrial contractions. Okay, a PAC depends on the underlying rhythm. Regularity will be interrupted by this premature atrial contraction. So all we're saying is that we have a normal rhythm, right? This rhythm is just beating on its own like normal sinus. Then all of a sudden you have something that jumps in the way and completely messes up your regularity. Okay. Now the P wave of early beat differs on the sinus P waves, can be flattened or notched, may be lost in preceding T waves. Sometimes it's hard to tell if you have a P wave, but there must be a P wave for you to technically call this a PAC. And I'm going to show you why. So let's take a look at this premature contraction that just occurred in this EKG. We see that it looks like it was probably just a normal sinus rhythm, right? Then all of a sudden, if we look at the distance between this R to R, this R to R became extremely short, right? Because we had a premature beat that occurred. Can we see that we have a little P wave in the front? Yeah, we can. All right. That's why I know for sure that this is what we call a PAC. Now you might say, hey man, how the hell am I going to call this? What are we going to call it? We would call it normal sinus rhythm with PAC. That's it. Pretty easy. All right, a flutter, atrial flutter. Atrial rhythm, that is regular, and the ventricular rhythm is also regular. Okay. Now, let's take a look. You're going to look at this rhythm and you're going to say, hey man, it doesn't even look that fast. The problem here is that the atrium is fluttering. All right. The atrium is firing off at an extremely fast rate, but it stays regular. It stays consistent at that rate. Now look how fast this atrial rate is, 250 to 300 beats per minute. The ventricular rate is going to be more like a normal looking ventricular rate. And we're going to take a look at it. Now this P wave, characteristic of a sawtooth pattern, some tests that you take might say picket fence. Some of them might just don't always try to be keen into these buzzwords like sawtooth or picket fence. What we're looking for is a faster atrial rate than what the ventricles are giving us. All right, let's take a look at it. So right now, we see that these R to Rs are consistent, man. Every R to R is spaced out. It looks normal. It looks like a regular rhythm. But what gets crazy is what's going on in between. Okay. So you can see why they say it appears like a sawtooth looking pattern. And look how many beats that we have in between each little rhythm here. We have a QRS, sawtooth 1, sawtooth 2, sawtooth 3, sawtooth 4, and then we have another QRS complex. Okay, if you ever see that, we call that a 4 to 1, right? We have 4 atrial beats to every 1 ventricular contraction. Now it says with conduction, it says the AV node blocks some impulses, but allows others through to the ventricles. Those that do get through are conducted normally. So that means that SA node is firing fast, right? Some of those are getting through the AV node and then conducting the ventricles or contracting those ventricles, but most of them are not. It's just the atrial keeps firing on its own pace, right? Be considered a flutter. Now you can see why a flutter can be so dangerous, because it keeps contracting and trying to squeeze out all that blood. And the fact that it's contracting so fast that it's not allowing enough blood from the inferior and superior vena cava to fill into that right atrium, right? Because it keeps contracting, so it's not allowing itself to fill. Problematic. And these patients can have a low cardiac output. This is why we got to slow down that rate. Typically used with a calcium channel blocker in EMS settings. Next one, AFib. You're going to see why AFib is going to look different than sinus arrhythmia, right? Remember, AFib is completely irregular, man. I'm talking the QRS complexes are irregular. The sinus depolarization is going to appear irregular. Everything about AFib is irregular. Now it says atrial rate that is greater than 350 beats per minute. You're not even going to be able to tell what the atrial rate is. It's just going to look so crazy, right? No discernible P waves. It's fibrillating, basically. PRI is unable to measure, but it's a normal QRS looking complex. So we look at this. Now, some of you might look at AFib and say, hey man, we got some artifact on the monitor. Make sure you always check your leads if you have artifacts. Sometimes I know riding in the back of the truck could be a little bumpy and you might have some choppiness on that isoelectric line. Just make sure you put those leads on fatty locations. Try to get a good read. AFib is always going to look crazy like this. Now, the one thing that's really going to give it away when you have somebody on AFib on your monitor, you're going to see that heart rate fluctuating, right? First, we're going to see the heart rate maybe at 80, then 110, then down to 50, then 70, then 110. It's all over the place. And you're like, what is going on with my monitor? If you need to print out the actual EKG itself, hold it up and make sure that your R to Rs are normal. If your R to Rs are irregular and you have what looks like artifact in between, you have what's known as AFib. Now, we all know the problem with AFib is it is a major cause of strokes, right? Now, it states the AV node blocks some impulses but allows others to proceed normally through the ventricles, just like with a flutter. And guess what? We treat them both the same if it is considered rapid ventricular response. I know I'm not going to get too much into treatment for this because I want to talk about actually reading the EKGs, but there is one thing I do want to say about AFib. Once our ventricular response becomes too rapid, aka a heart rate greater than 150, right? If it's greater than 150, we are going to give a calcium channel blocker to slow down the ventricular rate. There's nothing that I'm going to give that's going to slow down that atrial rate, right? This person has AFib. People live with AFib all the damn time, but we need to slow down that ventricular rate because if we don't, then this patient's cardiac output is going to drop and that patient could potentially code on you. Yep. Unstable, just like with any other fast rhythms, we can cardiovert that. Absolutely. All right, let's make this shit happen. We're going. Of course, we have sinus arrhythmia. I'm actually going to turn this on just to give you guys a couple seconds. Now, we already know this is sinus arrhythmia here, right? We can see that it is irregular. How about this rhythm right here? If you want to chime into the chat and tell me what you think it is, go for it. I'll give you a couple seconds to count it out. These are all sinus rhythms that we just talked about, right? All right, let's take a look. Sinus tach. Good. We see that it's regular. We have narrow QRS complexes. I got upright P waves, but we're still below 150 beats per minute, right? I got upright P waves. I got narrow QRS complexes, right? But the distance between my R to R changed. If we use our 6-second method, we see that we have, right, a heart rate of 50. We're looking at sinus Brady. Crazy ass looking beat here. And I like this EKG on here for a reason, right? The only reason why I really like this is because it looks crazy. And some people look at this and they're like, what the hell am I looking at, man? But we still have a beat. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is a rate of 100. We have an upright P wave. We just make the narrow, right? Because it's only 3 boxes in width. Even though there is depression, we're not actually looking at a 12 lead EKG, so we're not reading that. But this is still considered sinus tach. Let's take a look at what we got here. A rate of 30, upright P waves, narrow QRS complexes, sinus Brady. All right, what do we got here? Immediately, the first thing I looked at was that first beat. It looks like there's an extra beat right after the T wave. I think that was a mistake. We're not getting into U waves. What do we got here? Now, the only way that I would see that this could potentially be a wandering atrial pacemaker is if there was consistent irregularities in those P waves. There is not. I know that first one looks a little awkward, but this is sinus rhythm normal. All right, we got this EKG here, which we have upright P waves, narrow QRS complex, sinus tach. Good. right. That ain't artifact. Don't forget, when you see it looking crazy like that, a trick that I always tell people to do, take a sheet of paper, put the paper over the actual EKG, mark your R waves, and then move your paper around to make sure that they line up together, right? If they do not line up, you have an irregular rhythm. Right here, we're looking at AFib. Another crazy looking rhythm. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Remember the pattern, right? We have a sawtooth pattern. This is a 2-to-1, A flutter. All right, I see some irregularity here. Now, those first 3 contractions that you see there, we have upright P's, I have a QRS complex, and then all of a sudden I have some random irregularity right there in the middle of the EKG. Normal sinus rhythm with a PAC. Good job. All right, we got another one. So you can look at those distances, and then again, there is a random atrial contraction that's occurring, sinus contraction. So that makes it normal sinus rhythm with a PAC again, right? This one obviously looks a little bit different than the other one, right? But they're the exact same thing. Just looks a little different.